Hello, I'm Dr Mike Rutherford, Dentolegal Consultant at Dental Protection. Welcome to RiskMatters, our latest series of podcasts created specifically for dental practitioners in Australia. As the name suggests, RiskMatters is all about managing risk. In this podcast series, we will be taking your feedback and queries and putting them to leading industry experts, getting them to answer the difficult questions about managing risk and working safely. It's about what to do when managing risk matters most. In this edition, we focus on local anaesthetic and its use and possible complications. I'm joined today by Dr Greg Mahoney, who is a practising general dentist with an academic interest in pain control and local anaesthetic, having attained a doctorate, master's and a graduate diploma in these fields. He's held many academic and society positions in Australia and internationally, and presents on behalf of Septident. Greg provides continuing education for dentists across the world in IV inhalation and oral conscious sedation, local anaesthesia, and medical emergencies in the dental surgery. So welcome, Greg, and thank you very much for coming along to share your knowledge. When Greg walked in, colleagues, he handed me a draft of a book he's just written called Local Anaesthetic for Dentistry. So we've picked the right person here. So thanks for your time, Greg.
Thanks very much, Michael, for having me and giving me an opportunity to talk about local anaesthetic, one of my favourite subjects.
Yeah, we dragged Greg in on this on the basis of meeting him at ADX, and we were talking about life, and then within 3 minutes we were talking about LA toxicity, so we know where the area of interest lies. So I guess unless we're doing a checkup and clean or a consult, almost every other aspect of dentistry is prefaced by the administration of local anaesthetic. We check the medical history, we choose an anaesthetic that suits our needs and inject. Though not always successful, LA works for an incredible number of people, making invasive dental treatment tolerable. Greg, is it as simple as that?
Well, Michael, most local anaesthetics are efficacious, right? And so when we're choosing a local anaesthetic, we have to take into account things like the comorbidity of the patient. We have to take into account what we are trying to achieve. How long do we need it to be numb? What teeth do we need to be numb? So in doing so, in picking the right molecule, we have to take into account also the physical properties or the chemical properties of that particular drug. And that includes the pKa, lipid solubility, protein bonding, half-life, and what is the toxic dose of that particular drug. So in choosing those drugs, I think we have to take into all those things.
Mm-hmm. So, Greg, just for those of us who have been a long way out of dental school and pharmacology, what's pKa?
Okay, pKa is a constant. It basically means, very simply, the closer that particular drug's pKa to the physiological pH of 7.4, the better.
Right.
So, for example, lidocaine or lidocaine is a pKa of 7.8, 7.9, and articaine is 7.8, and bupivacaine is 7.7.
Right, okay. So they're approximating.
Yeah, so essentially what will happen is if you have got a pKa close to that pH, physiological pH, you'll have more ions available or more non-ionized local to cross the lipid membrane.
Great. Okay. So what's your opinion about local and, say, adrenaline and some medical conditions such as high blood pressure when you're taking these considerations?
Michael, I'd like to keep my life fairly simple when I'm doing dentistry. I basically, if somebody comes in and says to me, oh, I've got a heart condition or I'm taking this medication, I go, maybe I won't use adrenaline on that particular person if I'm giving a block. However, if I'm doing infiltrations, I really don't think it matters that much. Okay, so, things like high blood pressure, things like valvular diseases, that sort of stuff. But there are also some other conditions that we get concerned about as well. You know, thyroid toxicosis can be an issue. We've got people who are allergic to particular drugs, and that's another issue.
Okay. We might get onto those later, but just when we were chatting before we started, you had a fair bit to say about adrenaline, and when we were talking about the possibility of things going wrong, and I think you said that it's the adrenaline.
Yeah, there's not much that's a contraindication for local anaesthetic. It's basically if they're allergic to a particular drug, in other words, particular local anaesthetic, or whether they're allergic to other components in that local anaesthetic, like metabisulfates. You can get latex involved as well. Yeah. However, most manufacturers denature their latex bungs and diaphragms, so you don't really have a problem. I don't think there's ever been a recorded case of a latex allergy when using local anaesthetics. But it's the things like high blood pressure, coronary disease, valvular disease that you've got to be particularly concerned about.
So if a patient has a true anaphylaxis, and this actually happened to one of my colleagues in the practice, Andrea, who eventually bought my practice, and thank you very much, Andrea. She had a patient have a true anaphylaxis, as in swollen, red face, head swelling up, jumped out of the chair and put his head under the sink. And then got the raspy, wheezing breath. So
scary moment, I think.
Her voice was shaking when we did a podcast 10 years after the fact.
Yeah.
So what do you think the likely scenario was for that?
I think it's fairly rare, and it doesn't really mean that if somebody's allergic to, say, articaine, they're necessarily allergic to lidocaine or lignocaine. However, the ones they're most likely to be allergic to is ester-based local anaesthetics. But remember that a lot of your topical anaesthetics now are ester-based topical anaesthetics, and that is an issue.
Oh, okay. So what happens? We put on some topical anaesthetic and
they get an allergic reaction. They get quite often. It's the reaction is localized, right? So it's not necessarily how can I put it, life-threatening. However, can be quite distressing.
So what's this typical presentation for that? Because I wasn't aware of that. So could you just talk us through that presentation?
So the likely reaction to a topical anaesthetic is going to be increased heart rate. That's where you're going to see it. So you get the increased heart rate, possibly decreased cardiac output, so lowering of the blood pressure. But it will not. It usually is transient, right? It's not there forever. But the problem is, I think the real issue is using high concentrations of ester-based local anaesthetics. When I look at some of the preparations out there, there's compounding pharmacies that are producing local anaesthetics with 18% tetracaine. Tetracaine.
So are you talking about injectable local anaesthetic?
No,
or
this is
topical.
Just purely topical.
Right.
But they're now coming in kits where you inject them without needles. You inject them into the sulcuses.
Right.
Now, the issue is, of course, is that if you're injecting deep into sulcuses, they're likely to have inflammation in that area. So it's an increased vascular area. Right. So it gets picked up.
So should we use this as a warning sign not to carry on with injection if your patient reacts to the topical?
Well, it depends on what they're reacting to. If they're reacting to tetracaine or benzocaine, which is an ester-based one, then no, not really, because it's more likely to be a specific to ester-based. But the problem is, of course, you've got a distressed patient.
Yes.
I'm not going to proceed in that sort of situation.
Look, and that's good patient management, isn't it? Yeah. Sometimes we step out of the pharmacology and say, look, what are we doing about a patient in front of us who's distressed? Well, you don't do dentistry. Yeah. So,
well, we did have a case in Brisbane where a patient actually had a local anaesthetic injection, a block injection, and she immediately gave the typical response of an endovascular injection where you get that momentary increase in heart rate and you get this flight and fright type feeling. And she was quite, she's a bit distressed, but she calmed down and And she still went numb, and they still did the work. So they finished the treatment, and about 40 minutes later, she walked to the reception and then started convulsing, uncontrollable convulsing, right?
Okay.
Now, the dentist was cognizant of the fact to say, this is not normal, and called the ambulance service, and they came there pretty quickly. Now, that was the classic signs of somebody getting a toxic dose with one vial of lignocaine.
Hooey.
Yeah, because toxic dose is their best guess, right? So somebody maybe go off at the 7 milligrams per kg, which is the recommended, but they also may go off at, somebody else might go off at 4 milligrams, right? So most of the experts now say it's a guide only. Okay. The big worry is the intravascular injection. So it's very unlikely that you're ever going to get to those toxic doses with a infiltration.
Right. Yeah. But if you're getting it IV, then that's going to lower that threshold of,
absolutely,
grams per kg.
Yeah, because once it gets to IV, it then becomes 5 milligrams per litre.
Okay.
Right.
And how many litres we got? About 5 litres.
4.5.
4.5, okay.
Yeah.
All right, that's bringing the sums down.
Yeah. So if you give somebody, say, Articaine into a whole cartridge, 2.2 mil, you can get a toxic dose.
Oui.
Yeah.
Remember that, boys and girls. If there's anything you learn from today, just be aware of
it's essential.
injection.
It's essential that you aspirate, and aspirate.
So, Greg, any other areas of concern, polypharma or any other medical conditions?
Okay. Besides the coronary issues, I think we have to be cognizant of the fact that you can get drug interactions. So things like anticonvulsants can make things worse. So people who are epileptic can have issues that will bring on an epileptic with adrenaline. Protease inhibitors, some of the HIV type drugs can potentiate things. Sulfonamides can make things like methhemoglobin anemia worse.
Okay.
Even paracetamol can make methhemoglobin anemia worse, right? Fortunately, the doses that we normally give people of, say, something like prilocaine, which is associated with that, are so low that we're not likely to get methhemoglobin anemia, but it is possible, okay? Benzodiazepines, right, can potentiate, particularly something like midazolam. If you give midazolam and you use lidocaine, it can potentiate the effects of lidocaine on the cardiovascular tissue.
Well, that's interesting because sometimes midazolam is used in IV sedations.
Yes, correct.
Okay, we're going to go on to that in the second podcast, but that's interesting.
Okay, now some people are still on non-selective beta blockers, something like propanol. Most of the patients coming in your door will be on selective beta blockers, but if you have an unselected beta blocker, it can affect you as well. Calcium channel blockers, right? Lidocaine.
Well, that's pretty common.
Yeah, local anaesthetic drugs quite often will mimic the calcium channel blockers in the cardiac tissues. And, of course, the other one now that's coming through the door is recreational drugs.
Right.
Cocaine is really bad.
Yeah.
I mean, that can end up in a life-threatening situation. We find that things like the stimulants that kids are on now really do affect them psychologically. They start doing weird things under local.
Okay. So is there a case for trying to avoid adrenaline altogether, or is that overreaction?
No, I think that would be an overreaction because adrenaline helps make that drug work better, right? I mean, the reason why we do it is it vasoconstricts the area in which the drug has been placed. Therefore, the drug will last longer, right? It also means that if you've got vasoconstriction in the area, it's not getting into the bloodstream quickly. Therefore, you're less likely to get the toxic dose. So there's a reason why we use adrenaline. I just probably wouldn't use it on people that have got cardiovascular disease.
Right. Okay.
Let's see. So the drug. Do you want me to name Can I name the drugs?
Yeah, sure.
Okay. So the two drugs that I would really sort of lean towards was mepivacaine Love mepivacaine.
Yep.
And the other one would be just prilocaine with fellipressin.
Okay.
I mean, fellipressin doesn't have the same effects as adrenaline. It will constrict the area, but it won't cause peripheral ischemia either.
Beautiful. Yeah. And what about articaine? I mean, if you look at the therapeutic guidelines, there's certainly suggestions that it's not suitable for mandibular blocks, for IDN blocks. So you got a comment about that?
Yeah, there's a long history on that. Let's go back to 1976 when it was first introduced to Europe, and it was used in Europe for 20-odd years before it was available in Canada and UK. Now, what happened was in Canada and UK, they found that a certain number of patients were getting prolonged paresthesia following the blocks. And so that led to a very cautious approach by the US and Canadian and UK and Australian authorities to say, oh, don't use it on blocks. But when they thought about it, and it's a bit strange, this wasn't happening in Europe. You know, even though it had been in use for over 20 years, they weren't seeing that happening in Europe. And it was it's actually Professor Tara Renton in UK. Do you know Tara?
I know Tara.
Yes. And she found out that it actually wasn't articaine. Articaine was actually less neurotoxic than lidocaine or lignocaine.
Okay.
And they found out it was trauma. And in particular, it was the second needle.
Right. So you're talking physical trauma or chemical trauma?
Physical trauma.
Physical trauma, okay.
Because it's less cardiotoxic.
Okay.
Yeah. So I have no qualms in giving a block with articaine. However, most of my blocks are with mepivacaine because I don't have to think about the adrenaline issues.
Yes. Yeah. And I guess I should just pop in there that we are obliged to follow the therapeutic guidelines. So if that's the reference book that you're going to be judged on by AHPRA and any
there's significant international literature to say that that's not a problem.
Right, we'll leave it to the individual to work through that. Yeah. What about mix and match of local? So I guess maybe we just move on to that, whether it's a failure of local, so typically block, but you inject a IDN block and it's not effective or only partially effective. What's your strategy there? What do you suggest?
Well, first thing is the mix and matching thing. Dentists frequently will use combinations of local anaesthetics and topicals to take advantage of the unique properties of that particular local. In this situation, the dentist should be always cognizant of the fact that the systemic effects are a combination and they follow the principles of summation, so that if we give somebody 6% of the maximum dose of a particular local anaesthetic, we can only give them 40% of the second local anaesthetic.
Yes.
So that's a basic standard principle. So I know that some schools teach people because the metabolites are different, you don't have to worry about it. That's actually untrue.
Okay. Yep.
So my strategies.
Yes.
Okay. Strategies for local anaesthetic. So first of all, routinely I use buccal infiltrations because I can give them painlessly, and it works on all areas, both maxillary and mandibular. The only time I have issues with giving infiltrations is usually on lower 7s and 8s.
Okay.
So even 6s will go numb with something like articaine because it penetrates through the bone.
Right. So you're saying like a 45-year-old heavily built male, MOD on a 4-6, your go-to would be buccal
articaine.
Okay.
Yeah. If it was the 7 or 8, definitely not, right? Because you get that external oblique ridge, thickening bone. If you can see the outline of the roots, how when you look on the buccals, it's going to work. Okay. I know that people like Stanley Melamed say you can even use it for 8s. I'm not quite sure.
Not on my 8s, thank you.
Well, I've actually had a root filling on my 4-6 with just buccal up infiltrations.
Well, there you go. That's proof in the pudding, isn't it?
Yeah. So if I was giving a buccal infiltration and it failed, the first question I asked is, did I give them enough?
Mm-hmm.
Right. And that's usually the case because we usually give too much, not enough.
Okay.
Right. It's a principle of sedation. It's a principle of local anaesthetics that how much do you give? You give patients enough.
Mm-hmm.
Right? No more than enough, okay?
It almost sounds like a weasel word though, doesn't it?
Yeah.
Give them enough.
Enough.
Like,
how much is it?
How much is enough?
Yeah. But anyway, if we get some paresthesia is not quite working, I usually ask that question first. Have I given enough? Okay. If I've given them enough, then where have I giving it? Is there something that anatomically that's stopping my local working, like a tuberosity or something like that, then I look at that. Quite often we'll give typically they're usually upper sixes on a buccals that's not working, so I will give one slightly more mesial because we may have that, innervation going into the mesial root. And then if it doesn't work, then I give them a palatal injection.
Okay.
Right. So this is for the maxillary one. So for mandibular injections, so if I've given a mandibular block and I've got patients getting their lips a little bit tingly, but it's a hot pulp, the tooth's not going numb, and you go, oh, damn, So what do I do then? I will give them articaine, buccal and lingual infiltrations.
Okay. So that's your second string.
Yeah. And then I may even look into adjunct therapies beyond that. Right. And those adjunct therapies may even be something as simple as some non-pharmacological technique.
Okay. Such as?
Say for adults, it may be nitrous oxide.
Okay,
something like that.
Sure. Now, what about a variation on that where you've got a hot pulp on a 4-6 and you've got a profoundly numb lower lip, they're almost dribbling. What you go to there? So I guess we're saying this is different from not getting profound anaesthesia.
And you still is the patient exhibiting that this is when you drill into it, this is not pleasant? Oh,
just when you get that the turbine is spinning and the water gets on it. That sort of scenario. We've all been there.
Yeah, absolutely. And I mean, we all have good days and bad days when it comes to blocks as well. I mean, nothing like a few failures in one day to give your confidence a real downer. However, in a situation like that, what I'll do is I'll give them infiltrations both buccally and lingually. Okay. I mean, you've got to realise that innervation on a lower tooth can come from so many different areas. It can come from the auriculotemporalis muscle. It can come from ipsilateral. It can come from the buccal nerve. It can come from the lingual nerve. It can come from the hyglossus. It can come from the cervical. So it can come from all those things. But usually buccal and lingual infiltration will take care of those things.
Right. What about intraligamental? Do you recommend them or do you use them?
Look, the last time I did an interligamental was, you in shorts. I'm not a great fan because usually I've got the interligamental injectors in my drawer, but I think they're gathering dust. And certainly my present dental assistants who only been with me for the last 7 years wouldn't know what one was.
Okay.
Because I just think, if you're going to inject interligamentally, then you're really thinking about taking out that tooth, right? Because you don't want to cause any damage.
Okay, so you're talking permanent damage to...
Permanent damage, yeah. Now, there is some, shall we say, research out there to suggest that it doesn't cause permanent damage, but there's also some research that says that it does. So I err on the other side. And the same with interosseous injections. They work. There's no doubt about it. But it's scary stuff because you've got to get in between the roots of the teeth.
Yes.
Get into the cortical bone.
Yes.
Right? And you're giving an IV injection. If you're giving an injection into the interosseous space, you're giving an IV injection. In emergency medicine, you quite often kids will come in and they need resuscitating, right? And they cannot get a vein for love nor money. They will go down and drill into the bone and give an interosseous injection.
Yeah. Okay, I guess that's. I mean, I certainly was aware of that interosseous problem, and I mean, in my younger days, I guess I gave a few, but I would always warn the patient of the possibility of tachycardia before doing it. But that intraligamental, that's the first time I've ever heard of that.
I'm personally not a fan. Ever since Articaine came out, I haven't had to use it, and that's just me.
Yeah. So I guess you're pushing, not pushing Articaine, but you're certainly recommending it as your drug of choice, I guess.
Yeah, it's the most popular local in the world now. Yeah. I mean, the Americans are a little bit slow to pick it up, but they're moving that way. But everywhere else is Articaine.
Great. All right. Now, what about toxicity? Do we want to revisit that? Have you got any more thoughts on that?
Other than the fact is that, the one thing that we can do to prevent toxicity is actually not do an intravascular injection. Right. It's that simple.
Yeah.
Right.
I guess I wanted to revisit it because I sort of feel it's one of the things we have absolute control over, the amount of anaesthetic we inject. So we're not talking about the reaction that you can't be prepared for or you don't expect, but I mean you are if you're talking about intravenous injection of it. But we can control the amount of anaesthetic that we inject into a person.
Yeah, I think, and probably that's one of the drawbacks of Articaine is that the amount you can give them in any one time is a lot less because it's 4%, not 2%. It has the same, it's still 7 milligrams per kg, it's still 5 milligrams per litre, the same as lidocaine, same as bupivacaine. I think prilicaine's just slightly higher in 8 milligrams per kg.
Yeah.
I think.
Is this information on the PDS? So you open the box and it's there, or is it? What's your go-to for the amount of anaesthetic that we can inject?
Okay, so there is I think there is a guide on the PDS, right? Personally, if I'm giving an infiltration on the maxillary teeth, I'm using about 0.3 of a cartridge.
Okay.
Yeah, I'm not using a half a cartridge, just under.
Right.
If I'm further back, say where you've got more anatomical structures in the way, I'm giving half. Right. On lowers, I've seen every time all the new graduates that come and work for me, I watch them giving local, typically they're giving lignocaine, and I watch them giving local and they empty the entire cartridge into that patient, which is totally unnecessary. Half a cartridge is fine.
Okay, and I guess that's a message that Stanley Malamed always espoused as well. Just because it's in the cartridge doesn't mean you have to use it. And
Stan's working with 1.7 mil cartridges as well, not 2.2.
Yeah. So so I guess moving on from that toxicity then, when we come back to those adverse outcomes, what's the most common sort of adverse outcome you're going to get from local anaesthetic injection?
Okay, so the things that can happen in local is one is postoperative pain. You could Articaine in particular, if you're giving it right into the periosteum, then it can cause postoperative pain. You can get hematoma when you, especially people on blood thinners. You can get trismus. There's a few things that can happen, but they're not that common and they're quite transient in their nature. Nothing's really perfect. The only one thing that really is of danger is intravascular injection and toxicity.
Okay.
Yeah.
And that true anaphylaxis, if it's a
true anaphylaxis. So there's some lessons we learned from anaphylaxis as well, is that when the patient comes in and they say, I'm allergic to local anaesthetic, don't dismiss that.
Oh, look, absolutely.
We actually had a case where one of the dental student did dismiss that, and she was allergic. That particular patient was allergic to metabisulfates, and she did a full-blown anaphylactic shock, and it was fortunate that she was in a hospital. Okay. It was done in a hospital clinic. Yeah.
And look, I guess I'll emphasise that point too. One of the scariest moments I've had in my practice was a young woman I'd treated since she was 4 years old. She moved away when she met the boyfriend. came back about 4 years later, and on the medical history she'd written that she was allergic to sulphur.
Yeah.
And
which is not uncommon.
And I said, but what do you mean sulphur? And she said, local anaesthetic. I said, what happens? And she said, well, the first time my heart stopped and I went off to hospital in an ambulance. And the second time my face blew up and I had trouble breathing. And I said, why didn't you write that it's local anaesthetic? And she said, I thought you'd understand. I thought you'd know. And I guess that was a real warning. If somebody says allergic to sulphur, ask the questions. Nothing happened, but geez, it took me a couple of days to settle down after that one.
Yes, you took your pulse a couple of times just to make sure. I can understand that. Yeah.
But, and no harm came of it, but boy, there was potential.
It's also, we should be cognizant of the fact is that one of the things that we must have, and it's in the therapeutic guidelines, is adrenaline. The one thing that's going to save that patient's life is adrenaline.
Great.
So those EpiPens are worth their weight. The unfortunate thing about EpiPens is they only last about a year.
They only last a little while, yeah. What sort of things and what's the reference for what drugs or devices should we have to support life in normal clinical practice?
Well, I just go back to those. Remember those data sheets in the local anaesthetic? There, it actually stipulates. Okay. But also, I think in the therapeutic guidelines, it used to stipulate. I haven't looked at the latest therapeutic guidelines, but it's certainly in the edition before said you must have portable oxygen. You must have the ability to deliver that portable oxygen, right, and with positive pressure ventilation, so one of those PPV valves, must, and oropharyngeal airways, and that and adrenaline are the absolute essential things that you've got to have.
Okay, so an oropharyngeal airway, you mean a
Goodell's.
Yeah,
they're now called because there's different makers of it.
Okay, so I always knew it was Goodell's, but I guess. As well as that, you have to know how to put them in.
Yeah.
I remember back in dental school, we were taught you put them in upside down and then rotate once you're in.
You still do that?
Yes, but it doesn't seem intuitive. So unless you have that knowledge and unless you practice, my practice used to do IV sedations and we would all practice putting an airway in. And maybe people don't do that if they don't do sedations, if it's just local anaesthetic. But it's a good thing to know how to do.
I think that brings us back to a really important point, is that we should practice emergencies in our own dental surgery. Right?
Absolutely.
So when you get somebody in to teach the CPR, which is usually a half-day course, make sure that they're doing the CPR in the dental chair, making sure that it's your group that are handling that, because it really, to be effective in CPR, you probably need about 4 or 5 people to do it. And if you're not practicing it, when it comes to it, it just turns to custard. Yeah. All the really poor outcomes of dental, medical emergencies and dental surgeries have been relating to teamwork.
Yeah.
Holy hell, I don't know what to do here. I will call the emergency services people and they'll take care of it, and they stand back and watch the patient.
Yeah. I'll agree with that absolutely. Like we used to get do the CPR courses, and of course the instructors always wanted to do it in the waiting room where you had heaps of room. Yeah. And we said, no, we're going to be in the dental chair. Yeah. And we would role play. We would say, Liberty, go and ring the ambulance, and Liberty would leave the room and say, I'm calling the ambulance. So you're always aware of who was left and who had done what.
Well, one of those CPR mannequins, that will actually give you feedback about how well you're pushing and whether you got effective airways or not. They're about $400. They're not expensive when we consider what we spend on it. The other thing you'll notice that the trainers will do is they'll have you on the floor.
Yes.
Now, the problem with that, of course, is it's a damn sight easier to do CPR on the floor than it is in a dental chair. Yeah, so that's why and the dental chair should, and I think they all are now, rated for CPR.
Okay.
Yeah.
And I guess that's just on that if you had a patient have a heart attack in the chair, this is getting a bit off topic, but would you try and get them onto a flat surface on the floor, or would you just use the dental chair?
The sooner I do the CPR, the better. The sooner I get a defibrillator on that patient, the better.
Okay.
Right. So I wouldn't worry because, generally speaking, that patient's going to be more than 100 kilos, and you're trying to shift a 100-kilo patient onto on the floor and try. No,
I can understand that. We in a former life, we used to have an anaesthetist come into our rooms and do general anaesthetics, and apart from all the other criteria, one of his was if he thought this person was too big to be able to manhandle while unconscious, he wasn't prepared to do the general anaesthetic. And we respected that. I mean, that's looking ahead and thinking about not everything's going to go right, but what are you going to do if it goes wrong?
Yep. Exactly. Yeah. Yeah. So, I mean, before we start, and especially with sedations and general anaesthetics, we always had a team meeting. And the team was, if it hits the fan, what are we going to do? What's your job? What's your job? Right. So they all knew what to do. Right. And it's probably, incumbent upon even general dentists that are doing normal things to every now and again when they do their CPR training to sort of say, well, okay, what are we going to do? The biggest problem is what happens on Saturday morning.
Yes.
You've got your junior dentist and your junior DA.
Who's also the receptionist.
Who's also acting as a receptionist, and somebody has a turn. Yeah. That's the scary bit. Yeah.
That's a very good point, because we all practice when everyone's going to be there. Yeah. But good point. Yeah. All right, let's go to something a little more mundane. We're not unconscious. We haven't had a heart attack. This is going back to basics, but you're putting in a inferior dental block. Yes. And your patient flinches, so they've had a zap. What's your advice?
Get out of there. Right. Just withdraw. Okay, just withdraw slightly. I mean, you
totally,
probably...
or just come back a few mils?
Just come back a few mils because you've jagged the nerve, right? The real issue will be, remember, it's the trauma that causes the problem. And the reason why the second needle used to give was because patients didn't feel you actually. Right. You didn't get that jab, right? And certainly if you've gone in, you've hit bone, then you withdraw slightly, there's a chance that what's happened is you've done a little fish hook on the end of your needle, and that in withdrawing it back, you've got a really good agent to start tearing apart inferior dental nerve. So
that's a very good point.
But definitely just withdraw.
Okay. And I'm just going to go through a cascade here. So what if your patient rings you the next day and says, look, I'm still numb?
Okay. Right. In that case, and that normally the first thing is you sort of say, oh my goodness, that's terrible for you, and you've got to show all the empathy that you possibly can. You ask the patient to come back, and then you map where that is numb, right? And
so you do that within 24 hours. So
I would, if it's more than, say, 6 to 8 hours, I'd probably start doing, unless I've used something like bupivacaine or that, I would definitely do that. And then I'd just map where it's numb and try to assure the patient that this is likely to be transient. And if it's not, then I think I'd refer it off to a specialist.
Great. Yeah. So I guess I'll just jump in there from a medico-legal point of view. We absolutely say bring your patient back. I mean, you've got to get them in there. You've got to reassure them. You've got to look them in the eye and explain what it might mean and what you're going to do about it. So you'd put them off to a fax max, an OMFS?
Normally, yes, but that's actually quite a rare event now. Have you experienced a lot of...
Yeah. But I guess, I mean, in this role, people don't ring you up to tell you that things are going swimmingly well. We only ever hear the dark side or that the things that go wrong. So having members ring and say, it was from a block anaesthetic and my patient's still numb, several days later is not uncommon. Yeah. Most of the times it's through surgery and eights and things like that, and occasionally implants. Yeah. But not that uncommon that we get them from a block.
Yeah, and lingual nerve quite often?
Yes.
Yeah, because that's the one that's in greatest variation and where it may lie.
Mm-hmm.
And so quite often taking out eights can pain that lingual nerve.
So going back to that, if it was, say, the block anaesthetic, so you did a restoration, so there's no hint that it's any physical trauma from removing a tooth.
Yeah.
If you had prolonged anaesthesia past 24 hours, you'd be looking at referring at that stage?
I would be looking to ring the fax max and first up and say, this is what's happened. Mm-hmm. What are you happy to see this patient, or can you actually recommend somebody for that patient to see? And sometimes it's a neurologist.
Yes.
In those cases, I think I was involved in one case where a patient was given a Gow Gates block, which, as you know, is a quite high block. I mean, it's a I used to use it a lot pre-Articaine, and they missed the actual condylophobia and they went through the coronoid notch and end up injecting the local into the masseter and the fascia there, thinking that the fascia was actually bone.
Right, okay.
And that patient ended up with permanent damage.
Oh, geez.
Yes, I think that was a payout.
Look, we agree absolutely with that idea of the referral because I guess from a risk management perspective, one, you're getting an independent expert who will give your patient the best chance of a good outcome. But apart from anything else, once that patient starts wondering whether you did something wrong, or once Auntie Ina has suggested that, or the next door neighbour, you've got an independent opinion here about what's going on. And so it's good for the patient's management, it's good for their outcome, but it's also good for their psyche to get it independently confirmed that this is one of those unfortunate and unpredictable adverse events, if that is what it is.
Yeah. I think that also comes back to the issue of consent. I think I read somewhere where you actually, like I said, if you didn't write it down, it didn't happen.
That's exactly right, yes.
I remember looking at that. And in fact, I think I even quoted you.
Oh, good on you. Good on you.
At some stage. Anyway, quite often, we as dentists don't actually get the consent that we really should get when we give local anaesthetic. You got written consent, and there are written consent forms. I mean, I think Queensland Health actually has a written consent form for local anaesthetic. But generally speaking, as dentists, we don't do that. And so, and they rely on the verbal consent. Right. Now, the verbal consent, as far as I am aware, and you may correct me, is that it have to be almost word for word telling people what are the possible problems that could occur with this local anaesthetic, et cetera, and are you happy for me to continue? Now, that would have to be, I would think, in your practice manual. That
would be a very good idea. Where we get concerned is when people write down risk and warnings given. Because if that's ever challenged legally, it's what risk and warnings were given. How do you know that on that particular day for that particular patient, you gave the same that you say you do every time? When I was looking into this, I reviewed my practices.
I had all the risk and warnings for, say, something like a extraction. A great big thing. The paperwork was just enormous. And then and that's why I went to the verbal consent, but I had it in my practice manual and always, of course, had a witness. So
you'd give risk and warnings for local anaesthetic?
Absolutely.
And could you just talk it through? You're about to give me an injection, so...
well, first of all, I normally ask the patient whether they would like local anaesthetic for their filling, and I said, and I ask them, are you aware of the issues? And 9 times out of 10 they don't. They say no, and I sort of said, well, really the issues with local anaesthetic are really quite almost non-existent, but, you can have issues with heart condition and, conditions like thyrotoxicosis. You don't have any of that, so I don't think you'll have any problems. I usually just couch it like that.
So introduce the idea that there's a possibility.
Yeah, and leave it open to the patient to ask questions.
Absolutely.
Yeah. So they, if they've got any, that's the next thing. Have you got any concerns about this? Yeah, that's what I normally will finish with.
Yeah, it's surprising the different levels you see of adverse outcomes and the reporting of it. I did work in a clinic which I won't name, but a government clinic where for tooth extraction, death was on the list of possible adverse outcomes. And I was always surprised that nobody ever asked me why or how, but they were happy to look at that and then sign off on it. I mean, I always felt obliged to mention that it was very unlikely.
Actually, when I was looking into it also, I found an American consent form that actually said that. Yeah,
okay.
Yeah, it's possible.
Yeah.
I wouldn't sign it.
No. Just moving on then, I guess when we have people that have that prolonged anaesthesia or paresthesia afterwards, and we get a fax-max opinion, look, occasionally we get our members, dentists, ring up and say that they have put patients on oral steroids to try and improve the outcome of that continuing paresthesia. Do you have any thoughts about that?
Actually, no, Michael. I don't have any scope on that at all. It's beyond my area of expertise.
Right. Yeah. Okay. No, that's fair enough. So I guess that would probably be an indication that for most of us as general dentists, it is beyond our scope and maybe more appropriately handled by a fax-max surgeon, a neurologist, or even a general medical practitioner.
I would think you'd be going for a neurologist if you're starting to do that sort of thing. But anyway, that's me.
Yeah. So I think we've had a pretty good chat about that. You sort of wonder how long you can talk about local anaesthetic. Greg, after 40 years of practice, you've still taught me a few things and probably reminded me of a lot more. So, look, we really appreciate your time and thank you for all your efforts today. This is very relevant to us and it's very helpful. Thank you very much.
Oh, thank you, Michael, and thank you for the opportunity to talk to you about local anaesthetic.
And thank you all for listening. And we do hope this podcast was helpful to you, and we look forward to sharing more guidance with you in the future. If you like dental protection podcasts and you'd like to hear more, please subscribe and leave a review.